roving reporter, so you'll have to stand up if you want to ask a question, and I'll get the microphone to you. So who's going to go first with a question? Gentlemen, would you like to stand up? Your name and the question, please, darling.
Thank you. Yes, I'm Sharif Ibrahim, physician in London and Surrey. I would like us to ask about the diagnostics here. And we are speaking about the mammogram and the CT scans, which is really a very, very good technology in diagnosing cancer. But we knew the classical scan actually prevent one death in 2,000 scans. So I think the number is quite low. The other thing, I think the side effects of the scans, of the CT scan generally speaking, is quite high. At one time there was mentioning of something like a thermal scan, which was thought to be really a very good replacement to a classical mammography. But this has just disappeared. I don't know why. So anybody can really give us a bit of explanation for that?
So to answer from technical part of this question, so for the breast imaging, spatial resolution, contrast resolution, and the ability to use contrast media. So these are very important to increase diagnosis accuracy. The thermal scan you're talking about, and I read about it years ago. So they cannot resolve these three questions very well. The spatial resolution is not good because they use a different type of physical theory to capture the image. And so spatial resolution not good. They cannot use contrast media of any kind. And also the contrast resolution, that means can you differentiate from a disease from normal tissue? And that disease include mass calcification, sometimes in very detail because early cancer only have a very small size, calcification or like the small masses. And thermal scan cannot answer these questions. So that's why it's fade away. So that's one of the questions I can answer.
Yeah. What about the diagnostic yield of the KBCT?
Diagnostic what?
The diagnostic yield. I mean, just like say, for example, the normal scan is 2,000. We say one life in 2,000 scans.
Oh, that's you're referring to the cancer detection rate.
And any side effects as well?
Okay. Side effect, I would say it's breast CT, and I would say the primary risk we're talking about is the radiation. Right? So I presented that the radiation is low and even below the FDA screening limit. So why we can achieve that is because of technology and also we only expose the breast in a very low dose, and we can achieve the low dose. Although it has a name of a CT on it, but don't relate this CT to a body CT. It's not like a high dose for breast use. And also, what's the next question? The cancer detection rate. Cancer detection rate is more of a term used in screening. So right now, the cancer detection rate of mammogram is about between 4 or 5 per thousand. And DBT slightly increased that about 1 or less than 1, that kind of range. And MR goes up to 16 to 20, some range. And we didn't do that because right now we are kind of pretty new. There's not like a so large scale study on this, but we have some ways to, some model, try to put our detection rate into that kind of mass population level. So we are in the same range or maybe a little bit higher than MR in that population. And I believe if you take a look at our brochure, and there's a chart that compares us with the other modalities, and one of the, that's the CDR, the cancer detection rate. Yeah. And we have reference underneath.
Amazing. Thank you, Doctor. Right, I'm going to make my way over here.
I've got a pretty loud voice.
Oh, yeah, but it's for the video, so we have to, yeah, sorry. We can pass this back towards this lovely lady.
Thank you. Hi, I'm Kat. I'm a physiotherapist. Thank you all for your talks this afternoon. They're absolutely fantastic. My question is to you two gentlemen, just with regards to the scanner. Have any sort of, are you able to modify the positioning for somebody that can't lie prone?
We've found for biopsies, for instance, because most of the time for just the regular scan, they're just laying down. If, for instance, ladies sometimes will have a frozen shoulder or whatnot, we can modify. You can be creative, as long as you're getting the same coverage. But for the most part, it's 7 seconds, so most of the ladies are able to accommodate for that short period of time. We have looked at it because the dosing is so low compared to mammogram when it comes to, I think, scatter for pregnant patients, which is something that I think the literature may bear out. Again, I'm going from just a few experiences we've had. But you know, the question is, can a pregnant lady lay on her stomach for 7 seconds? I mean, we can modify as needed because it's better than nothing. But I think to answer the question, yes, we can modify, we can be creative. That's the nice thing about pretty much all imaging of the breast, you can be creative.
Thank you.
Mm-hmm.
Kat, do you mind passing that lady behind you? She was in before.
Catherine Hunt, radiologist. A couple of discussion points. I think the CT breast development looks really interesting, and but I want you to tell me why you haven't included ultrasound in your comparison. I mean, it's a very important part of triple assessment, and you skated over it, so one would never really use the 3 modalities that you put forward in the comparison in that way in diagnostic circles. I think you should differentiate between screening practice and clinical diagnostic work, because they are different.
So I can
The other thing, and it was on your last slide, was the assessment, David.
Oh, I get stuck with
It was on your last slide.
Sure.
You did mention the axilla, but all through both your talks, the axilla was pretty much ignored. And of course, if you're doing a diagnostic ultrasound with digital mammography, you can get very good accuracy rates together, because ultrasound will miss the microcalcification, which will be picked up on the mammography. Now, I do think the CT looks a really helpful extra way of looking at things, but I'm sorry you underplayed ultrasound.
So with regards to ultrasound, I don't know if that's going to come across or not, but I do also have a bit of a loud voice. Ultrasound is definitely important in there. The critical thing, especially when it comes to the screening aspect for ultrasound.
Oh, no.
Just purely diagnostic?
You wouldn't screen with ultrasound.
Well, I mean, but the accurate study shows that that's actually good, especially in dense breast. That was the one that bore out for the literature. So as an adjunct, exactly. I mean, ABIS was the one that was proven, but the problem is not many people do ABIS. They want to do handheld. Handheld is good, but you have to be very conscientious of this, who's scanning. If you just throw somebody in there to scan, they're not interested in doing the right way, you're going to miss things. I think it's a very good adjunct for screening. I think this also will answer the question for high density. The reason I put in that slide, that was more speculative for axilla, because that really actually came from that European article, and that was, I mean, for instance, you're going to see a note on an MRI, you're going to do an ultrasound. You're going to see a note on a mammogram, you're going to do an ultrasound. Why not just automatically do an ultrasound? Because the other advantage of the ultrasound, and I'll put that in the diagnostic workup protocol, because for ladies, ultrasound biopsies are always easiest of the 3 or multiple options that we have. So we can see it on an ultrasound, that's the way we're going to go at it. If not, we do have the backup of, and my policy is always the same, always have backup, always have ways of getting out of trouble that you might cause in your own. So ultrasound being the easier way to do a biopsy, that is included. It's just we didn't present all the protocols that we're working up with regards to going from screening, how you work up certain things. But focal asymmetries that pan out to be real, masses, we'll do ultrasound on. That's part of our policy. They will come back and automatically get that as part of the diagnostic. I don't know if that answers the question.
It's a discussion, really, isn't it?
Yeah. So I have a couple of things to add. Why ultrasound is not, primarily compared with us. And first of all, that in our study, and ultrasound rarely be used alone for diagnosis. So it's hard to, when I designed a lot of the study protocol. You cannot say, okay, this patient has ultrasound, then move to KBCT scan. Let's compare how that goes. And I can assure you that with the target ultrasound, a lot of cancer may be totally missed in ultrasound and be picked up by KBCT. So that's usually we don't put this comparison in that unless we use ultrasound as adjunct to the primary modality, like KBCT plus ultrasound versus mammography plus ultrasound. That kind of comparison, I would consider that's a fair comparison in this kind of scenario. And we do have one paper that's published in 2016. They compare KBCT without ultrasound and diagnostic mammography plus ultrasound. And so that kind of comparison is very interesting, and we still yield very similar and higher accuracy compared to that modality. And meanwhile, if we add contrast, then things are totally different. So a lot of time, a lot of scenario, we don't put ultrasound as a separate column in the comparison because it's hard to achieve a fair comparison between these two modalities. And then we present directly with side-by-side with mammography and MR, and because that can independently reach some sort of conclusion. Unlike ultrasound, it's adjunct to another modality.
Yeah, do mammography and ultrasound together, it would be a dual assessment.
So far we haven't really compared KBCT plus ultrasound versus DM plus ultrasound. We haven't done that yet. But there's a study done KBCT without ultrasound compared with a DM plus ultrasound. It's published in one of the papers in 2016. So that's all.
And what was the conclusion of that paper?
Yeah, the conclusion is that we are superior compared with DM plus ultrasound. Yeah, that's and also about the auxiliary. That briefly.
We're going to do the axilla regardless. You don't see because that's going to tell you which nodes looks if they have a suspicion on the joint biopsy. I don't see ultrasound going anywhere. Like I said in my talk, the mammography techs are the ones that have kind of attacked me to say you're going to lose my job because ultrasound techs are safe.
Excellent. Thank you so much, doctors.
Thank you. Sorry, I wanted to ask if there is a variation in reporting, radiologist to radiologist, as far as the standard mammogram goes and the CT scan. Is the difference is less with CT scan compared to mammograms? So there would be, the reporting would be individually, could be different, radiologist to radiologist.
So right now there's 100% uniformity since I'm the only one reading most of these.
Yeah.
But what I'm trying to, as we train more radiologists to read these, trying to develop a template. Now obviously there's going to be some free-form dictation, so that's part of the art of what we do. But at least hit the critical points, and the critical points to me are going to be obviously, comment on implants, and on findings, where it is. You can always have a clock face because you've got 3 planes. You can localize it very well. Give it an attenuation, which helps because if they're going to get contrast, we know what the baseline is, so we have that. And I like to have a location as well. And the reason for location is because if I'm reading a study, and I'm in Georgia and I'm reading a study that was done in California, and somebody has to follow me for diagnostic, I can tell you how many times going with DBT where I spend 5 minutes of my life scratching my head trying to figure out what it is I'm actually looking for. Then you find it, then they go through and they do multiple images, et cetera, et cetera. This, what I found is I can go right to the finding. So I'll say coronal image 332, there it is. It takes me like under a minute to find it, so I know what I'm working on.
Do you see AI coming up and automatically read these scans? Is that a possibility?
So I don't see AI So we were actually, the other day, we were at a, I guess I can say, we were at a pub with an AI executive, Randy Waters. And so we talked about this, and I said, this is my only concern with AI is that you guys market so terribly, because you have people saying, well, AI is going to make me appear on the internet as if I'm a pedophile or God knows what, which is not what you're doing. Or AI is going to take my job, so nobody's going into radiology, which is also not what it's doing. I think the answer to the question is I think AI holds tremendous promise, in particular for this, because we're giving them a data set that I think is going to be more easily adaptable to AI. And I think it's going to be a very nice synergy between what I do and what they provide.
The results could be sent internationally to different sites to be read as well, I presume?
It is, and the other thing that I probably don't need to say, but most of the studies that you've seen are not on a mammo monitor. These are on 4K monitors, and you can see them just fine.
Fascinating, this equipment coming. And I love the idea of the reduction in false positive, reduction in false negative, and you talk about a day and a half to set up. But even though every life saved is so important, the elephant in the room has always been the cost of such an implement. And in a healthcare system, where this could be used by a private entity, but in the National Health Service in any country, what is the actual cost of setting up something like this? Now, sorry about this. My second question, in the break, I was talking to you about your last slide, and clearly a lady of color. And I was asking in relation to what could really be done in terms of improving the screening and early screening and the difference, if any, in ethnic origins of the patient. Please, I'd like if you could expand a little on that in terms of what we could do, because I saw it was quite emotional and it touched me, and I want to get a little bit more on what could really be done to reduce that particular incidence of potential death because of late detection or the genetics in relation to the treatment. So, sorry for two questions, but the first question is to you.
Yeah, thank you. So, speaking of the cost, I always think the cost of the machine is break apart by different phases. You have purchasing, you have installation, you have maintenance and running. So all these costs, that's how you own this machine. So I can only speak of how to prepare for the installation. I've been involved in multiple installation, and usually the preparation of the installation is just basically you remove whatever in that room. And a typical room like 10 feet by 40 feet, remove everything in that room, prepare the power, and you don't need any water or anything, prepare the power and floor, make it look beautiful, and the machine can just be rolling and connecting with the power. Of course, network and things, IT preparation that needs to be done, and a couple of weeks before, and that's it. That's
sorry, but cost effectiveness, a mammogram would cost so much. This would cost how much more than?
No, not much more, not more, because the room itself, you don't need a special shielding. The device itself shielded. So if you have a mammo room, and basically you can install the device in the same type of room. So I would say the installation does not cost much. Then you bring the mammo machine into the mammo exam room. And so for running and maintenance, it's just like running a mammo machine. So X-ray, self-shielded X-ray. Unlike MR, you need all of those kind of maintenance. This maintenance is just very straightforward and simple. And I don't see any cost in the maintenance so far in our sites. And the device runs pretty reliable, and especially those key components, rotating and X-ray parts all run pretty reliable. So the maintenance cost is very minimal. So I don't see anything that cost of get this wrong.
One thing, just as a quick for comparison of cost, just to consider, and I'm not the money man, I don't know the answer to actual numbers, but the real comparison is comparing this machine with biopsy capabilities versus a DBT that can also do contrast mammo and then has the add-on to do biopsies. That'd be the interesting comparison, and I think this one comes out actually costing less.
Thank you, Dr.
Okay, a
Mel.
question.
Oh, sorry, yes, okay. And then we have one last question, then we have to carry on.
So thank you for that question. So I think there are two things. Let me just start by addressing the genetic. So this lady was gene negative. Gene negative, what I mean by that is she was negative for mutations of the high-risk genes that we know of, and they are just a handful of genes. But we know that these genes explain very little of the familial breast cancer risk that we know of. And what we now know is that it's actually, we think that the genetic risk is actually explained by small changes in the genome, so they're single nucleotide polymorphisms that individually will increase your risk only by a small percentage, but if you carry enough of them, you could be at a higher risk. So this is something called the polygenic risk score. And polygenic risk score has been shown to be very useful, but again, only in the European population. So there are several publications that have shown that it can discriminate women as being high risk to low risk, but it's not been validated yet in women of other ethnic origin, which is why I am collecting the DNA samples and the tumor samples and creating a database for this. So there's a lot of work that is being done to understand more about what is driving this difference, but as far as we know so far, there is a difference in the kind of cancers that we see in ethnic minority women. They tend to be more prone for aggressive kind of cancers, and they present quite late. And the other crucial aspect is awareness. That's why I always try to include it in our talks. Not just awareness for our patients and the public, but awareness among the doctors as well. To just have that extra radar to think a little bit more when you see women from other backgrounds. Maybe take a few more minutes to explain to them, to say that if you or anyone else in your family notice a lump, just come back in and we can look after you. And then talk a little bit about the need for screening, because when I spend time with women of other origins, like the South Asians in East London, a lot of women came up to me and said, breast cancer is not a disease that affects us, it's a disease of the white population, why should I go for screening? And it's just that as soon as I explained why it's important, they're like, oh, if someone explained to me, I would have gone. It's not that difficult to go and get it done. So as healthcare professionals, we need to open our discussions with our patients, raise awareness, and also contribute to research. When I consent my patients for the samples, it's 3 times as hard to get women from other ethnic backgrounds to agree to the research when I compare to women of European origin. So it's a lot of effort that needs to go into this. So we all need to work and make sure we address this gap in the data that we have now.
Thank you, Doctor. And one last question.
So my name is Dr. Martins. I'm a gynecologist. So one question for the radiologist is, in America, what age are you start to use this machine? Because in England it's different. The screening is still age of 50. That's absurd. But how it functions in NHS. So even if I want to have, if some patient needs this, they're not going to do an exam. So they need to go private. And what studies you have for England about if you have any for if this machine is really good for screening breast cancer, calcifications, or because we have lots of mixed race like myself, South American, Africans, and we know in dark skin color the cancer can be quite more aggressive, even if they have mutations, there are lots of things happening. So this is my question.
I mean, I think that that's a tough one. I mean, we were talking, I had a patient this week, a 26-year-old that's probably going to have multifocal disease. So I don't know, you know, the problem is a lot of that's dictated by forces outside of our control. And as much as we say, you know, I mean, when they decided to start screening at 40, there's a lot of politics involved. And so that's just the reality of when, you know, how we decide this. I think from a medical standpoint. And I would say you've got to assess the genetic risks, you've got to assess familial risks, and you've got to put everything. I mean, it is. I mean, my experience has been, you know, ladies of color, a young lady of color with breast cancer scares me more than just about anybody. They do, for some reason, they just have much more aggressive cancers.
Can I just add, in the NHS in this country, if you're at higher risk, you can be screened from 40.
As you know, you need to, I mean, lots of check box. I'm doing medicine for a long time. I came from another country, so we're more linked to America when I was working. So we were more proactive on this. I used to start mammogram at 35 of my patients. When I started working here, I was 35 because 50 years old in a country like that, people will be diet is awful, English breakfast every day. It's not possible. These people need help. So, and you cannot send, if they are 45 or 40, they need to be strong family history. A BRCA, a mother, sister, is not black or white.
Right.
You can send the patient, they don't have the exam done. I'm speaking about NHS, even private. If you don't follow the protocols, you can put yourself in trouble. If you don't follow the NICE guideline, because you have the GMC on your time, on you all the time. It's not like in America, it's open, it's private service. You need to work according with the protocols. If you don't work, if there is any complaint, you can lose a license. That is the problem.
In our clinical trial, when we designed, we used like 35, different groups. If you are a diagnostic group, you are allowed 35 to be enrolled in the study. And that actually was changed by a doctor at that time, the PI. Initially we said, oh, everybody 40 and above can be included in this trial. And that doctor said, well, it's a diagnostic trial, then let's lower that to 35. So you find the cases in our database that are 40 years younger, and they still have breast cancer. But as Bonnie mentioned, it's beyond our control about what age you get to what.
Yeah, but in America you can start quickly if you think, because it's more private. If the patient goes to you, you can have this exam done if you think she needs.
I'm not sure if off-label use is the thing in the UK.
Okay.
Yeah, so in the United States you're allowed to do off-label use.
Yeah, like Brazil, we have freedom, we have tight control. Because if you do private, you need to use the NHS, and then the problem starts, because why did you ask this exam? It's not the NICE guideline, you don't use that, and then they put loads of things in the mind of the patients, and the patient comes against us.
Sometimes we do see off-label use, like when you say, or if the doctors think it's appropriate to use certain technology, and they are allowed to, at least by FDA, they are allowed to do off-label use.
Yeah, because I'm asking you how it's going to be. I think this is very good technique, but how it's going to match it in the private and NHS? Because some patients, they can do something privately, but they cannot have the treatment privately. They end up maybe with the consultants in Royal Free or something like that. But she knows about the machine, but have loads of consultants never heard about this, or they think, and then they want to put the patient all the burden again. New biopsies, new treatments, it's really difficult. Yeah. It's another system.
It's more about regulatory.
Do we have any politicians in the audience?
I think we're all agreed we need a bit of consistency across the globe. But that's another discussion another time. But thank you so much, Doctor, for bringing that up. That's really, really good. So doctors, thank you so much for answering those questions so eloquently. If I could ask you to please.